great pleasure here at Anam Cara today to have Dr. Charlie Cork come and speak for our Dying to Know Day event, which is national on the 8th of August annually. We feel that that his book Letting Go is very relevant to this day, this National Day, and so we were very pleased when he agreed to come along and join us today, and thank you all for coming. The format of today we thought would perhaps be most beneficial if we had a little bit of a question and answer, interview type scenario between the two of us, and then give you guys an opportunity to ask any questions if you have any questions at the end as well. Dr. Cork's kindly brought along some of his books, which he's agreed to sign for us if anyone would like one. And normally it's $30, but today it's $20, so that's a good thing too. So we may as well make a start. I shall start by asking a few questions, so I'll take a seat as well in our little interview console. So our first question really is, what made you write the book?
Well, I've been a doctor, an intensive care doctor for ages, for a really long time, and I can't tell you the number of times I've sat in that awful room, the waiting room in intensive care, and spoken to families about what shall we do. And amazingly frequently you get in a situation where you can save someone if you really try hard. It's likely that they'll die, and it'll likely that it'll be a long and difficult battle, and if they survive, it's almost inevitable that they'll be a lot worse off than they were before you started. You can do it, but do they want you to do it? And outcomes now, with modern medicine, we're able to keep people alive for a very long time in a way that may not be at all acceptable to them. So we know that. And so I've had so many conversations with families about what should we do? And families just look at you and haven't got a clue. Even if you live with someone for years and years and years, you just don't know what to do, and you're stuck between a rock and a hard place. And it's terrible. And then, of course, when I say families, there's a whole mix of people in the families. There's the son from Hong Kong who definitely wants you to do everything, and the daughter, who's lived with mum and says no, and then, and then all those family dynamics come out, and it's a mess. It's a total mess, and there's nowhere to go. And without guidance, we do it. So everybody who says my family and my doctor will know what to do when the time comes, is sadly deluded. So it's a mess. So we need suddenly, what we've got, thank God it's not me. So we've got, with modern medicine we can do so much, and just in my lifetime modern medicine has come so far. It's just amazing. You get chest pain in the morning, you're zipped in, you get choppered somewhere, you get stented, and you're discharged in the evening. It's all over. When I was training, that killed you. It's amazing. It's fabulous. There's lots of things like that. But with all that massive advance, there's cost, and we now have to actually work out how much is too much, because before we couldn't do too much. Now we can. Life support's become really quite tough. And so because of that, I realised that this choice is necessary to make, and I reflected over my time, and just feeling how lost people are, and when they've made the decisions, seeing people, we now have this new syndrome of families who have post-traumatic stress syndrome because they've been put through the decision-making process. It's sad. And equally, of course, people get treatment that they desperately wouldn't want if they just had a chance to say so. So trying to communicate that. I did start writing the book to write it for doctors, but I realised that that's hopeless. That doctors actually, the reality is that doctors are the curers, the healers, the miracle workers, all that stuff. That's, the best doctor's the one who saves everybody, by brilliance. And we don't like to move away from that. So if we're not going to get given any guidance, we're going to do it. We've got all the stuff. And there's a whole load of other things that make it inevitable that we do things. Getting in and getting x-rays done quickly, the system. Those of you who've had a bit to do with the system will know how amazingly it sucks you in. It's like, you just can't stop it. You shoot through. And so thinking is hard in the process. So I think really it's down to us. And when I gave a talk in New Zealand, their Writers' Festival, and some bloke at the back stood up and said, "I've got it, this is about activism. We've got to be active. And we've got to be activists to stop it happening to us and to protect our family." So it's a bit like wills as well. We all don't want to leave our family in a mess. And this is ultimately the way you leave your family in a mess, not doing anything. So it's, to me, it's pretty logical. But we've got to bring it down to actually personal responsibility and getting on with it. So the book's a lot of stories and a lot of explanation of why it matters.
I guess our next question really is, who did you write it for? But I think you've answered that really there.
It's for you.
So
Yeah.
It's for us, which is wonderful.
And I'm pleased a lot of people have bought it and said, "I bought 3 for all my children," which is the goal as well.
Mm.
You know, this is to tell you, because it actually, as we'll come to later, in order to make this work, it's not signing a form. It's not doing the legal form like the lawyers think. This is a system. You've got to lock it in. And so understanding how to do it and getting everyone on board is really important.
So reflecting on the book, is there any particular story that you like?
Well, life's a hard thing, isn't it? Because they're toughy stories. But I suppose that the one that resonates with me is probably the first one, which is before I ever became a doctor and I was a medical student, and it was my granny. My granny, if anyone ever gave an advanced care plan clearly and repeatedly, it was my granny. Because she said, "Never, ever let that happen to me." And she said it repeatedly, all the time, and there was a lot of things that she related that to. And so it's pretty clear, and you could honestly not have felt that our family had not been told, because we had. But of course, as she became older, she started to get dementia. And with the dementia came a number of medical crises. And every time she had a medical crisis, we loved her very much. She was a very central part of our family, very dignified, very powerful lady. And every time she became sick, we did all the things that good families do. We got the best doctor for her, we got her into the best hospital, we insisted that they looked after her quickly, we criticised them when they didn't. We rushed to the chemist to get, before they closed, to get the antibiotics for her. We did all the things that you do. And of course, by doing that, we managed to make sure that she got to the point that she said that she never wanted to get to. And eventually she was incredibly demented with a nappy. We did keep her at home. Well, when I say we kept her at home, of course my auntie did. I didn't do much. I was a medical student and bloke. Didn't help very much. But, visited regularly. And then one day she developed, she had atrial fibrillation from her heart, and a clot from her heart went down her leg and blocked off her leg, and she had a white leg and she was screaming and upset. So of course we called the doctor. You got GPs coming home in those days. And he came, and we were expecting her to go to hospital. I diagnosed it because I was a clever medical student. Talked about how the clot needed to be pulled out. And he just paused and he said to us, "I'm wondering if this is really what she'd want us to do." And as soon as he said that, it was obvious to us as a family. It's like that light switch that switches. To everyone in the family, it's perfectly obvious. There's no way we could say, "No, yes, this is exactly what she wants us to do," because there was nothing for us to work with from that. And he said, "No, I could keep her comfortable, make sure she give her pain relief, and we could keep her here." And as soon as he said it, it was obviously the right thing to do, and we all did it. But up until him guiding us a little bit, we were just on the do-it-all thing. And I see that so often, and I've sort of felt that we didn't do the right thing for her. We did it all for the right reasons, and that's so often that everybody does things does the wrong thing for the right reasons, and we have to be very careful of it and be aware of it. So really, before I even started, that was a really big thing for me, and I felt that GP showed me something very important, which was to give guidance and to think about the patient's perspective rather than all the system stuff that drive us. So thinking about all those things that was very important to me. There's tons of other stories that are all very similar and explain and I wrote stories. The stories aren't, apart from my family ones, which I've identified as being, and I haven't divulged the details and the names of other people. And actually, a lot of them I put a few cases together because they're so frequent that you just mix up a little bit of stuff. But the messages are there in the stories. So telling stories and explaining it. But there's lots of them. I don't know what the favourite stories isn't perhaps the right ones, but most meaningful.
Yes, I imagine you've come across some very complex situations and difficult ones. Thank you for sharing the story of your granny. Why do you think we don't plan?
But it's interesting, isn't it? Because we plan for wills. You know, we don't want to leave a mess for our families, and that's about. And no one says that if you make a will, you're thinking that you want to die. You're just being practical. So making a plan for this, for me, is practical. I suppose part of it is that people don't know, that people have trust that if they don't plan, it'll all work out all right. And increasingly that's not the case. So somehow, and part of writing the book is to try and explain that it is honestly impossible. So when you see someone that said nothing, we assume that you want everything. So we will assume, and we have to assume, that you will want to go to a nursing home with a tracheostomy and a peg tube and a urinary catheter. And we will assume that. And the family will feel that part of love and duty involve ensuring that that happens. And to try and veer from that is really, really hard. It's hard for doctors and it's hard for families. So, part of the revolution, I think, is that we need to realise that we have to give permission to our families to let go, which is why the title of the book was that it's about permission to let go. And without it, we feel very compelled to do lots of stuff. And I'm amazed with my medical and nursing colleagues how often they come and tell me that their parents or parent has been in the system, that they have been quite clear trying to convey the wishes to doctors, and that the doctors, they say, why are doctors so obsessed about doing all this stuff? And then I think, well, heavens, if people who are, the nurses I deal with are pretty tough, and the doctors know what's going on, and if they're having trouble, what's it like for everybody else? The system is so pushy to do all of this that you really need to be really confident in order to manage it. So it needs permission, I'm afraid, from the person so that the family know that, and the doctor can be really confident that making this decision, which is tough as heck, to not do stuff. It's easy to do stuff, and it's hard not to do stuff. So you need permission not to, and how you get there is really the second half of the book. Is about how to get there.
Thank you. What do you think makes a good plan then?
Well, that's interesting as well, because we've come a long way with all this planning stuff. And it started off with tick boxes, I don't want CPR, I don't want dialysis, I don't want this, that and the other, and that really worked pathetically badly. Why? Because people said, I don't know, it all depends. And of course, people were right. The Office of the Public Advocate, they're lawyers, so they're up in Melbourne, and they're the people that make the decisions when the family aren't there. And very structured and legal brains, whatever. And they've observed the same thing that we've observed, which is that clear statements, I will not have, are quite difficult. As soon as you look at them, you think, oh, I wonder about that. Would she really know what was involved? And does no always mean no, or does it mean sort of maybe not? And you're instinctively querying it as soon as it comes up. So in fact what they say and what we've observed is that a little bit of poetry and a little bit of narrative around the thing works much better. So things saying, I've had a good life, I don't want to mess up the end bit, I know that your decisions will be difficult for you, but please respect my wishes, is really meaningful, as opposed to something that says I don't want this, that and the other. the list, which doesn't work so well. So a plan that's thoughtful, looks human, and then again one that all the rest of the family are locked into. Because the other error is making a plan and then not sharing it with anybody. So the locked up plan in the solicitor's office that comes out after the event, when you're not able to say anything, is not really helpful. That comes as a huge surprise to the family. The family always query it. If I wasn't involved in making it, I will query it. And a lot of people say, oh, my family are too busy. No. Or my family are too difficult and I want to leave them out because they're too difficult. But actually saying, please respect me, is really important. And I've had plenty of families who come and say, we don't like it, but she made us promise. I think, good, all right.
Thank you. Our next question is, what do you think makes a good decision maker?
Well, so that's the other thing. In the active part of the advanced care planning is making a plan, and I'll just go back to the new plan in Victoria now. It's got two bits to it. It's got a values plan and an instructional plan. A bit. Any old plans that are in existence are still valid, and in fact, you need to know that a plan that isn't even written down is still a plan. So doctors will be most impressed, and lawyers will be most impressed by the Victorian, like official plan. So if you can do that, it's useful. But if you just do any sort of plan, is better than no plan at all. And then appointing a particular decision maker, because this is not an easy thing to do with a committee, and a committee of family members. And if you think I do see some families that get on really well together and admire each other and work well. But it's not common. So actually picking a decision maker. So what makes a good decision maker? Well, a good decision maker doesn't go, he loves me most, and that's why he appointed me, and you would never liked you. That doesn't work at all. A good decision maker is someone who says, I have this responsibility to do this because he's picked me because of something. I'll story in a minute. But your views matter. But I have the final decision. But coming to that decision, your views matter. And I want to get second opinions from other doctors and from other people and put it all together. But at the end of the day, this is my responsibility as opposed to my honour to do it. And then also someone who's able to make a decision without waiting forever for evidence. You know people in this life who can never make a decision because they're looking for another piece of information and they can't ever get there. Well, they're not going to work on the day. So that's not really good. People who jump to conclusions really quickly with no information and don't listen, they're no good. So you want someone in the middle. And then you want someone who, having made the decision, will go, I made the best decision on the day, and that's how it is, and that's it, it's over. And doesn't spend the rest of their life regretting it. Because we've had some people who are appointed who do it, find it a terrible burden, and then feel very, very guilty about it. And then the other thing to say about a decision maker that I've observed is that a lot of people, older people, will appoint their spouse. And the problem is that the natural history of life is that if everything goes well for us in this day and age, we'll probably get to 80 without too many bumps, but not many of us will get to 90. So it'll all happen between 80 and 90. And not many people between 80 and 90 are their children allowing them to make any decisions without getting into it. So, they're just not going to accept it. So you've appointed someone who is going to be trumped and have a lot of difficulty. So unless you tell them to rack off, that it can be difficult if you appoint someone who's also going to be trumped. So appointing a good person, and you may not find someone like that in a family, and I've seen some very good ones who are family friends as well, and that takes all the emotion out of it. A good decision maker, and in the book I've got There's a great Croatian family, and I don't know whether you know many Croatian families, but certainly medically, Croatian families are right up there with emotion and stuff in the thing, and then lots of them. So they're complicated. Decisions with Croatian families are complicated. So when this chap came in and I saw a Croatian, I thought, well, I'll put some time aside. But he appointed his business partner as his decision maker, and the business partner was super. He sat the family down and said, it's my responsibility to do this, and listened to them and gave them all a chance to have their say, and then say, now you respect that he's asked me to do this, please respect me, because that's what he wanted. And they did, and he said, well, if it was me, I think I'd have the operation, but I know exactly how he feels, and I think it would be exactly what he would not want, and I'm going to make the decision not to. And they said, well, thank you very much, we could never have made that decision, but I'm really glad you did it. And then he said, now my job is to look after you for him and the family, and I thought that was really beautifully done. So it can be done really well, and so taking the emotion out can be a good idea. So thinking about who a good decision maker is really important and works well. So good player, good decision maker.
It's very, I think, important and interesting to hear that it doesn't have to be someone in your family that necessarily is that decision maker, and that the advantage of thinking about who that person is that can do the critical thinking at the time without too much emotion in it. I think that's really good to take away. I guess another question would be, when is a good time to complete an advanced care plan? Or an advanced care director?
Yeah, no, look, the right time to do is now, okay, for everybody, because I'm presuming that anyone let's have the moment of truth. Who has an advanced care plan? Okay, so good on you, but that's a very small minority in this group, and you are actually an exceptional group because you come to listen to me. So the fact is that if you haven't got one, I'm going to presume that you do want to go to a nursing home with a tracheostomy, a peg tube, and not recognising your family, because that's exactly what we're going to do. So if you haven't done it, we're going to assume that. We have to assume that. That is what we do.